Today I'm going to be discussing the shoulder, posterior dislocations and fracture dislocations. You may be aware of these books, Where's Wally? And this is one of the problems when people look at radiographs. They notice the obvious abnormality and then they stop looking. They suffer from satisfaction of search. I'd encourage you, when you look at a radiograph, an obvious abnormality, look around the radiograph for all the other abnormalities that might be there. Here we see the radiographs of a 48-year-old male who has severe pain in his left shoulder. There's no known trauma. He's got a limited range of movement and tend over the posterior shoulder. Those radiographs get reported as normal. Fortunately, the patient represents 2 weeks later. Now we get the full trauma series, the AP, the lateral scapular view, and the axillary view. And I'm going to give you 30 seconds to look through these radiographs, looking for all 5 abnormalities. Well, I hope that you would all have seen Wally by now. And so when you get a good axillary view, you can see the classic posterior dislocation of the glenohumeral joint. We see how the humeral is posterior to the glenoid. Village policemen can make that diagnosis when you have a good radiograph. You might have noticed Wender on lateral scapular view, the humeral head posteriorly centered to centered on the Mercedes-Benz sign. Oddlaw and the light bulb sign, old school light bulbs. The wizard shows us the relative increased distance between the glenoid and the humeral head. And those of you with a keen eye might have noticed Whiff and the lesser tuberosity bunched up shoulder is dislocated. Contrast that to the initial radiographs, AP and the poor lateral scapular view, which in retrospect now it's obvious, and particularly if you're doing a talk on posterior dislocations, it's obvious. But unfortunately, these injuries continue to get missed. In retrospect, once again, you might notice a subtle abnormality here of the lesser tuberosity. And posterior dislocations still get missed. They got missed in 2005, they got missed in 2001, and missed in 2013. And unless you get the full trauma series, you will miss a posterior dislocation. If you put shoulder trauma and radiographs into Google, you'll find many variations of the axillary view, the valpolateral. Here we see leaning to the side to be able to get a good lateral view. One of the problems with these, where the patient is sitting up, is it can cause pain and discomfort. And the radiographers are loath to sit the patient up and to cause pain and possibly harm. If you know what you're looking for, though, and you put radiographs in shoulder trauma, and just look a little bit further back, here from 1988, Ian Kelly, he wrote up these radiographs series and talked about the apical oblique. The nice thing about the apical oblique is that you can get that radiograph with the patient lying in the bed. You don't need to move them. And what you're really looking for is the relationship between the humeral head and the glenoid. And here we can see clearly how this humeral head is posteriorly directed in relationship to the glenoid. Very difficult to miss a posterior dislocation with those kinds of radiographs. Same patient returns a year later, now with the right shoulder. Previously it was the left shoulder. Here was the history for the left shoulder. Here's the history for the right shoulder. Right shoulder pain, no history of trauma, and clinically the right shoulder is dislocated. Much harder to miss clinically because you see the clinical deformity of the anterior dislocations. Radiographs are a lot harder to miss because you can often make the diagnosis just on the AP radiograph. And in fact, if you have a look at instability in the presence of seizure activity, anterior instability is more common, but a posterior dislocation in the absence of any form of trauma is seizure activity. It's pathognomonic. And if you've got a bilateral posterior dislocation, that's your answer, patients having seizures. So here we are with our patient. He's 2 weeks later. He's got a posterior dislocation of the glenohumeral joint. And what are you going to do now? Pause a little to think, how are you going to reduce this? Are you going to reduce it closed? Are you going to reduce it open? Are you going to do it in the ED or take the patient to theatre? And once you've reduced it, how are you going to hold it and how are you going to rehabilitate that patient? I'm going to give you 10 seconds, but if you need a little bit more time, and this is not about my answer, but about your answer, then just put the pause button on your YouTube video and think about how you might reduce, hold, and rehabilitate. Thumbs up. This is what I've done. So we saw that there was not a lot of bone defect on the axillary view. We saw that the lesser tuberosity had almost been fractured off on its own. And so I would have tried a closed reduction. But if the closed reduction didn't work, I'm then thinking about opening it. And most of the stuff is in the front. So pectoral. Once you've gone through delta pectoral, through the deltoid and pec major, gone through the clavipectoral fascia, you then have your considerations of how you're going to go through the lesser tuberosity. Your options there: lesser tuberosity osteotomy, subscapularis tenotomy, or subscapularis peel. In fact, in this scenario, the patient has already almost done their own lesser osteotomy, and so as such, I simply completed that. If the lesser tuberosity is intact and subscapularis is intact, for subscapularis, Robinson talked about it nicely in his review article on posterior dislocations, how if you open up the rotator interval, you slide your knife along the superior border of subscapularis and then open up the interval between supraspinatus and subscapularis, and you can then often see into the empty glenoid. You can see the humeral head as it's locked out the back. You can put a ring handle spike or trithowen from anterior to posterior to disengage the head and then use it as a skid to reduce it. Here I've used a lesser tuberosity osteotomy as described by Neer. Wouldn't have been totally unreasonable to do a McLaughlin, and that's where you do this subscapularis tenotomy. But the patient had already done their osteotomy, so there's no point then cutting subscapularis off the broken lesser tuberosity. I fixed this down with a large bore cancellous screw and a washer. You could have used a third tubular plate, just 2 or 3 holes of a third tubular plate, buttressing it in. You can use anchors. There's many ways of fixing it back down, your own personal choice. Let's have a look at that Neer's paper from 1987, where he talks about the lesser tuberosity osteotomy and advancing it into the defect. They had 40 patients with 41 posterior dislocations. And you've already done the maths. There it is. There's someone having seizures, isn't it? Someone's had a bilateral posterior dislocation, pathognomonic for seizure activity. The diagnosis was missed by the initial physician in the majority, which is a little bit sad in 1987. But I suspect that cases are still being missed now. Mechanism of injury was high energy trauma, motor vehicle accidents, or seizure-related activity. The average interval from injury to diagnosis was 1 year, and just over half were diagnosed within the first 6 months. So if you miss it initially, you won't always be lucky that the patient will come back at 2 weeks. And the auxiliary radiograph confirmed the diagnosis in all shoulders. You don't need special imaging, you don't need a CT scan, you don't need an MRI scan. What you do need, though, is a good auxiliary view, and I would commend to you the apical oblique of Queally, 1988. Of the 41 cases that they had, 7, the deformity was accepted. And that's because, in fact, once you've had a posterior dislocation for a while, you erode the head, particularly if it's been months or years, and you can achieve elevation to about 100, 110, 120 degrees. You can compensate. And so there are some patients who would be more than happy to live with the stiffness and deformity rather than consider reconstruction, particularly if they've now eroded the head, and your reconstruction would be some form of arthroplasty. Because we know with hemiarthroplasty for trauma, you would achieve active elevation only to about 90 degrees with a pain score of about 2 to 4. 12, they tried a closed reduction, and of those, only 6 were successful. 9 had a subscapularis transfer, and of those, only 4 were successful. And 4 had a lesser tuberosity transfer, and 4 were successful. This is not a competition between the subscap transfer and lesser tuberosity transfer. For me, I'm normally going to do a lesser tuberosity now. I like the idea of bone-on-bone healing. I like the idea that I then have substance to be able to transfer into the defect if I so need it. 9 had a hemiarthroplasty, 6 were successful, 10 had a total shoulder, and of that, they considered 9 to be successful. Now, watch out for arthroplasty in the presence of patients having seizures. Go back and read Robinson's article and read about the difficulties of treating shoulder instability in that population group that's continuing to have seizure activity. Here we see the radiographs of a 32-year-old, 2 months following their injury. They were seen in a shoulder clinic and in fact sent for an MRI because of a stiff, weak shoulder and possibly a cuff tear. I'm going to give you 10 seconds. Report says that it's normal. Yeah, we can see that it's not normal. We see there the light bulb sign, which could mean that it's just an internally rotated arm. But on the lateral scapular view, we see how the humeral head, and that's a beautiful lateral scapular view. You won't get a better view than that. We can see how the humeral head is orientated posteriorly in relationship to the glenoid. And when the MRI comes back, surprise, surprise, there it is, the posterior dislocation that's been missed. There's a little bit of a head defect, and in my calculations, I'd say that this is less than 25%. And you need to think about the head defect and what you're going to do about the defect. If it's less than 25%, you can often achieve a closed reduction if it's an acute injury. If it's a delayed injury, you might need to open it, and you can then open it either by just using Robinson talking about the rotator interval, continue that down into a subscapularis tenotomy and do a McLaughlin. Or for me, I would actually curve it around the lesser tuberosity and do a lesser tuberosity osteotomy and advance that into the defect. If it's between 20 and 50%, then you generally do need something to put into that reverse Hill-Sachs lesion so that they don't keep engaging that reverse Hill-Sachs lesion when they go into internal rotation. And as such, you would do your lesser tuberosity osteotomy. If it's more than 50% of the articular surface, you need to build it up. Otherwise, they will just continue to engage the defect when they go into internal rotation. In the younger patient, relatively good quality bone, and where you want a biological repair, you might elevate it. Elevated it by opening up the greater tuberosity or the lateral aspect of the humerus and punching it from below. You might consider an osteochondral allograft to recreate the normal anatomy of the shoulder. And in a slightly older patient, an arthroplasty, whether it's a partial arthroplasty, hemiarthroplasty, resurfacing, or total. So how are you going to reduce this one? You could try closed, but you're going to fail in some, as we read from Neer's article. Most people have talked about going from the front, but I find that occasionally what helps is to use a percutaneous posterior approach. I'm not talking about a formal posterior approach to the shoulder, but you use your posterior scope portal. You put your ring handle spike with Rothowen in that posterior scope portal, and you can feel how it slides down the articular surface on the back of the head and get between the head and the glenoid. And you can then use it to lever the head out. Use it as a tire iron to lever it out, and then as a skid to slide the head in. And if that head fragment is attached to the shaft, you can then, once you've disengaged it, externally rotate the arm and reduce the head. It's often much easier to do the rest of the approach once the head is reduced, because the anatomy returns to near normal. If you can't get it from the back, then you can still reduce it percutaneously from the front using that rotator interval. Open up the rotator interval, separate subscapularis and supraspinatus. You can see where the glenoid is. You can see where the head is in the back, and put a ring handle spike and disengage it from the back. On this occasion, once I've got that reduced, I wanted to elevate that head fragment. It was a small, relatively small amount, but whenever you put him into internal rotation, it was now 3 or 4 months down the line, the posterior structures had completely stretched out, the anterior structures had tightened up, and so every time I brought him with his hand onto his tummy, the head defect would engage the reverse Hill-Sachs lesion and he would fall out. And so then what you want to do is fill that up with something. And on this occasion, I've elevated the depressed bone, held it with headless compression screws, and then advanced my lesser tuberosity osteotomy into the defect. So here we have a 74-year-old who wakes confused, slightly pyrexial, and has shoulder pain. Likely having seizure activity, that's why the CT head is there. Slightly more complex, so I'm going to give you 60 seconds, and we want to find again all 5 of the usual suspects. So I hope by now you've all seen Wally, the light bulb sign, internally rotated arm. Yeah, we see the glenoid on face on the lateral scapular view with the humeral head posteriorly directed. So we found Wender. Oh man, there they are. Village policeman can make that diagnosis. There's Woof, the posterior dislocation of the head. Now the head fragment is disconnected from the shaft. But while I'm looking here at the head fragment, I'm also thinking about odd law and going, well, in fact, there's no defect in that head. There's no reversial sacs. But this head is disconnected from the shaft. Time is up and we haven't got to the wizard yet. Do you see the wizard? There he is. That's the first view of the wizard, is this idea of the spike on the metaphysis. And you see that quite nicely here on the lateral scapular view, this spike of metaphysis attaching to the head. And that's quite important. When we go to the CT scans, village policemen can make the diagnosis on the axial imaging, the posteriorly dislocation. Let's just have a look at those axial scans though. So there's no large head defect. This head is disconnected from the shaft. And I see how that head fragment continues on the spike and how it comes out from the shaft sort of posteriorly. While I was there, I saw that there was no fracture of the lesser tuberosity. There is a little bit of fragmentation here, but lesser tuberosity and bicipital groove on continuity to the greater tuberosity. And so this is a two-part fracture. What does the coronal view add for us? Don't think it adds much. Sagittal view, in fact, this is the slice on the sagittal view that is the winner. And I see this medial metaphyseal spike coming onto the head fragment. And what that medial metaphyseal spike and the head fragment tells me is that the blood supply to this head will revascularize. Because now we're thinking of Hertel's classification, aren't we? We see how the articular segment is separated from greater tuberosity, separated from lesser tuberosity, separated from shaft. So it's one of these four. But there's no real fracture of between the tuberosities, and there's no separation of the tuberosities from the shaft, and therefore it's this top two. And so it's this two-part fracture dislocation where in fact the blood supply has been disconnected from the head. And now you go back and read Hertel's paper when he talked about the Legerbrick classification, and he talked about the predictors of vascularity, the articular fragment separated from the tuberosities and the shaft. But then he also talked about the medial hinge, and he talked about this medial calcar. And so the fact that this patient has more than 8 millimeters of medial calcar means that although this head will be dysvascular, there's a good chance that it'll revascularize over time from that posterior blood supply. We saw that spike, the wizard. We saw it there on our plane films. So what approach are you going to take? You could come deltapectoral on this one. Not bad approach. You could come extended anterolateral. What I would probably do though is try and reduce it first. Now, can you reduce this closed, remembering that the head fragment is now disconnected from the shaft? You can still, if you do this percutaneous posterior approach, put your ring handle spike through your posterior scope portal, disengage the head, and just use your thumb at the back and push that humeral head back into place. If you get it reduced, often it looks relatively anatomic. Then all you need to do is connect that head fragment to your shaft, and the less soft tissue disruption you do in terms of interrupting your blood supply to that head, the better. And so for me, an extended anterolateral. With an extended anterolateral, I can also get my finger around the back of the head. You can feel it there, how it bulges. And so disengaging it with the ring handle spike and using my finger or my thumb to lever that head back into place. I don't have to open up subscapularis. I don't have to open the interval. I can then put my plate down. If that posterior percutaneous reduction doesn't help, if I can't manipulate it with my finger, through the extended anterolateral, I can still get to my rotator interval. I can still do a lesser tuberosity osteotomy. It's a little bit more difficult, but I can still do it. It all depends really on what you need to do. If I've got bone loss and I need to advance my lesser tuberosity and I'm doing a lesser tuberosity osteotomy, I might most likely probably going to cut the pectoral, because that brings me right onto the right place to help me with my approach then to that lesser tuberosity. So here we see the radiographs at 6 weeks. This was a percutaneous reduction and the plate just slipped down the side. And I know what you're thinking. Yes, Lee, you can't say that there's no AVN at 6 weeks. And in fact, you can't say that there's no AVN at 1 year, because it'll double if you wait 2 years. And here we see the radiographs at 2 years. You might think that that screw has caused the arthritis, but in fact, the patient went on and had a CT for other reasons, and he's actually developing arthritis on the other side. I don't think he got any AVN of the humeral head. You know, it's not uncommon that you see it at the top corner, a little bit of resorption, a little bit of sclerosis. Overall, a good shoulder. at 5 years. Here's another case, a 70-year-old who has seizures and a bilateral shoulder pain. Going to give you 60 seconds. Focus possibly on your left, the image on your left, which is the patient's right. And the image is on your right, the patient's left. Focus down here. What's this piece here? What's this? What's that represent? Okay, my interpretation of the x-rays on the right, I see a humeral head, but not all of the humeral head. And I see the continuation there. So this is the head split, the one that was defined by Neer as the impaction fractures. He was talking about these posterior fracture dislocations. That's where the humeral head with the seizure activity has gone towards the back of the glenoid, the force has continued, and just like a ping pong ball, it's just crushed the artifice and the subchondral bone into the metaphysis, into the humerus. But that head fragment is still attached to the shaft. It's still attached to greater tuberosity. There's no fracture of the lesser tuberosity here. He's just crunched up that subchondral bone. On the other side, again, I see the same sort of thing, a head defect, possibly on that view. But on this view, I'm seeing actually quite a lot of the head is there. And this is the one where the head has gone all the way out the back, got stuck on the back of the glenoid. And so there's not a lot of head defect on this one here. There is a fracture of the lesser tuberosity. And that's what that abnormality inferiorly is all about. Let's have a look at the axial CTs of both shoulders. And in fact, when we see the scanogram now, we see how the greater tuberosity has a crack between the greater tuberosity and the shaft. And so I'm seeing that same pattern of Hurtle where the articular fragment is separated from the shaft. I'll just play that again. I see lesser tuberosity broken off the shaft, so that's another piece. I'm not going to define it as a part yet because Neer told us a part was 1 centimeter and more than 50%. And you see how the shoulder on the opposite side is slightly different. Here it's not really about breaking that head fragment off the shaft, but what he's done here is the ping pong ball crushed all of that subchondral bone, and it's more than 50%. And so here I'm thinking about the head defect problem on that other side. If we have a closer look at the shoulder, the axial images, lesser tuberosity attached to the shaft, head fragment attached to greater tuberosity, but that articular defect crunched in. And so here, if you're in your 20s, 30s, 40s, 50s, maybe, what you need to do is elevate that head fragment. And you can elevate that head fragment through a window in the greater tuberosity. You could osteotomize the lesser tuberosity to give you access to that fragment and then elevate it and push the lesser tuberosity into the defect. With that amount of defect, more than 50%, you're not going to be able to fill that defect just with lesser tuberosity. So doing a Neer procedure is not going to be enough. You're going to bring back the articular surface. If you're in your 60s, late 60s, 70s, 80s, I'm now thinking some form of metal, whether partial arthroplasty, hemiarthroplasty, total arthroplasty. On the right-hand side, when we have a look at the axials, we see how the head fragment is separated from greater tuberosity. Probably a few osteons still holding there, but in all intents and purposes, head fragment is separated from greater tuberosity at the articular level. And so when I see that, we go to Hurtle's paper and the vascularity of the head. We look at the sagittal images, and I see head fragment with no real calcar. So this head is dead. The chances of this head revascularizing in this patient's lifetime is low. There's a good chance it's going to collapse. On the coronal images, again, don't think they help me much, but they show me how greater tuberosity is separated from the shaft, separated from the head fragment. And so on that right-hand side, because the head was dead, patient was in their 70s, I've gone for a hemiarthroplasty and a stemmed arthroplasty because greater tuberosity and lesser tuberosity have been disconnected from the shaft. I need something to anchor it on. You might notice the anchor at the back. I stretched out all the posterior structures. So here I've done a posterior remplissage of infraspinatus and of that posterior capsule, because recurrent instability can be a real problem, particularly if they're still fitting, if they're still having seizures. On the opposite side, it was really just a case of bringing back that head fragment and building it up. And instead of punching it up in poor quality bone, I've done a hiplasty. Copeland taught us that you can put a hemi in the rheumatoids on 60% of bone. Here there was only 50%, but I've built up the remnants with cement. And there you see the radiographs at 2 years. Last case, 44, has fixation of a proximal humeral fracture somewhere else. Comes back, and here we see the radiographs. And it just doesn't look right. And you might be able to see it on a zoomed image here. With eye of faith, you can see it there. Oh man, don't accept lateral scapulars. When you see the axillary imaging, axial imaging, you see clearly here how the humeral head is dislocated posterior to the glenoid. You would have seen that quite nicely with an apical oblique or an axillary view. And you may think, well, they fixed that head fragment, they reduced it, fixed it on, and then it just got knocked off again. Patient may have had another seizure. But if you have a look at this axial imaging, you'll find that in fact those screws have never gone into the head. There's no drill holes in the head. And so what they've done is they've relied on an apical radiograph and they've relied on a lateral scapular radiograph and haven't quite appreciated the fact that there's a posterior dislocation, which the village policeman can make that diagnosis. Wally can make that diagnosis if you have axial imaging. So what do we do about it now? Well, the head fragment is disconnected from greater tuberosity and lesser tuberosity, so now I'm worrying about the vascularity. And here we see the sagittal image. I've just done the still here, but I see 8 millimeters of calcar on that head fragment, which tells me that although that head fragment is disc vascular, there is a chance that it'll revascularize from the posterior blood supply, from the posterior circumflex humeral vessels. And so what do I need to do now is get that head back in. It's a few months since its injury, so it's not going to be easy. I could consider coming from the front, doing lesser tuberosity osteotomy, but that'll further devascularize his head, further interrupt with the soft tissues. It's not going to be great going in there. They came extended anterolateral initially, and so that's what I continued. Extended anterolateral, took out the screws, which were in the breeze, then ring handle spike percutaneously from the back to disengage the head from the glenoid, finger around the back and pushed it round and managed to reduce the head fragment into the glenoid. It's not perfect. It's still angled slightly posteriorly, but it's back in joint. There actually wasn't a lot of bone loss here. There wasn't a lot of humeral head loss. And so the reverse heel sacs, I didn't have to fill. And in fact, once I'd got that reduced and 1 or 2 screws from the same plate into the head fragment, I then tested the patient. I brought them into internal rotation, put the hand on their belly, made sure that that head didn't disengage, or didn't engage the reverse heel sacs lesion, made sure that I could get their hand to the back pocket so that that reverse heel sacs lesion is not engaging the glenoid. Because if that's the case, then you don't have to go any further. These are the radiographs at 2 years, and it's 2 years for a reason, because we know that the incidence of AVN will go up the longer your follow-up. And we see, thanks to that inferior calcar fragment, that that head is revascularized and the head is healed and it's remained in joint. In summary, please, please get an axillary view. Don't accept just an AP and a lateral scapula. Otherwise, we will continue to miss posterior dislocations. Think about the head defect and the size of the head defect. If it's less than 25%, between 25 and 50, and greater than 50%, and think how you're going to deal with that engaging reverse heel sacs lesion. Think about the duration of dislocation, and if it's been out for a year or so and their function is good, consider doing nothing. Go back and read Neer's paper. If it's been out for a while, think about your approach and how you're going to reduce it, whether you're going to reduce it closed, whether you can reduce it percutaneously, or whether you need to open it. And if you open it sequentially, open up rotator interval, and then think about subscap tenotomy. Personally for me, outline lesser tuberosity, osteotomize the defect. You can use it to fill the pieces in. As for your approach, delta pectoral, extended anterolateral, depending on how you're going to fix it and your next step, where you need to be. I don't think there's an absolute right or wrong on that. Thank you.